but limited resources, and various coordinate all various disease programs. So these are the two major principles of IDSR, integration and coordination. So the evolution of IDSR from 2001 to 2019 essentially is to tell us how IDSR evolves from 2001 to 2019. In 2001, IDSR technical guideline was developed, which basically includes epidemic-prone diseases, surveillance, and diseases targeted for elimination and eradication. When it was revised in 2010, non-communicable diseases were added to the list. Public health emergencies of international concern, IHR 2005, and developed and implement national policy on IDSR in 2010. So as we move along, in 2019, when we concluded we developed or we revised the IDSR technical guideline, we have the third edition of IDSR technical guidelines. A lot of inclusions, modifications were made. Some of the new areas, very important, are disaster risk management. You have point of entry and IDSR, risk communication, and very important, electronic reporting of IDSR. That is electronic IDSR, which is a surveillance outbreak response management and analysis system, which is SOMAS. And it further elaborates on event-based surveillance, which is a key component of our early warning system, community-based surveillance, which is a new frontier, IDSR in One Health concept. These are all elaborated in the new technical guideline. And it is important to also note that in the third edition, we have 45 priority diseases. 25 are reported as case-based, which means we report immediately, particularly using our surveillance tool, which is SOMAS, and 25 are for 25 of immediate, then 20 were diseases of public importance, which we report 11 weekly, which we use MSAS to report mobile strengthening of epidemic response system, to report the weekly reportable diseases, which are 11, and then we report 9 monthly reportable or aggregate through the DHIS2. So the evolution of also of priority diseases, which of course we have mentioned earlier, but I just want to, this slide is intended to just highlight the evolution also of priority diseases from 2001 or 2002 to 2019, which I mentioned earlier, from 22 priority diseases in 2002 to 45 priority diseases in 2019, according to IDSR Technical Guideline 3rd edition. In summary, some of the objectives of IDSR are as follows, which are in line with the strengthen capacity to conduct effective surveillance activities, involvement of clinicians and other cadres of health staff in surveillance activities. IDSR intends to strengthen all this and then integrate multiple surveillance systems so that tools, personnel, and resources are used more efficiently, just like I mentioned earlier in terms of area of integration as a principle of IDSR. Improve the triangulation and use of information to detect changes in trends in order to conduct a rapid response. Also improve flow of surveillance information between and within levels of health system using electronic tools like IDSR, like SOMAS and MSAS. And then build strong laboratory systems. As I mentioned before, in 1998, laboratory systems were not, strengthened to support surveillance across the country. But in this IDSR technical guideline is aimed to build strong laboratory systems and network of national, regional, or district level. And then, of course, trigger epidemiological investigation and implementation of effective public health interventions, to mount an effective response to public health emergencies, and also emphasize community participation in detection, reporting, and response to public health problems. As I mentioned earlier, one of the new frontiers is community-based surveillance in the IDSR technical guideline that will guide in this objective, which is community participation. So some of the public health surveillance, the uses, which we're all aware, I'm here just to remind us on some of these uses: to detect sudden change in disease occurrence and distribution, monitor trends and patterns, portray the natural history of a disease, help us to develop hypotheses and stimulate research, detect changes in health practices, evaluate control measures, and facilitate planning. So I want us to understand the purpose of this topic. As we can see, IDSR core functions and levels of implementation. We know the core functions is to identify, report, analyze, investigate, prepare, respond, communicate, and evaluate. But the most important aspect on this slide in terms of this presentation is the level of implementation. When we look at the community level, that's why we, Nigeria Center for Disease Control, have developed a community-based strategic plan, which is aimed to guide implementation of community-based surveillance across the country. At the second level is health facility, and that's why we intend to strengthen secondary and tertiary health facilities in terms of surveillance. The health facility could be public. During my opening statement, I mentioned that we have not forgotten about the private health facility, because we are aware that surveillance, people attend private health facilities in large numbers. And so we need to really strengthen the private health facilities for effective surveillance across the country. And public/private health facility could also be primary health facility, secondary, or even tertiary health facility. So other levels are local government, which you are aware, the states, and at national level. We are all aware of the SOMA's deployment at the 774 local governments, and even at the state level, not even at the local government, because the state DSNOs and state epidemiologists are fully involved and supervise the local government DSNOs in the reporting of data through surveillance, outbreak response management, and analysis system. And then at the national level, at the level of coordination of all these surveillance activities across the country. So why strengthening IDSR implementation in secondary and tertiary health facilities? The health data is a driving force. Essentially is to strengthen quality data, so that it will inform decision. Surveillance data provide the information for decision making, health planning, resource allocation and management, identifying, preventing, and controlling outbreaks of diseases. And quality of data and completeness of data cannot be overemphasized, because once the data has no quality and is not complete, it will be very difficult for us to use it as a tool to guide our decision in terms of healthcare interventions. Surveillance data are generated at facility level. We're all aware that most of our data right now are generated at facility level. So hence the need for us to strengthen the ability for the secondary and tertiary health facilities to report data at that level. The tertiary and secondary health facilities play a critical role in public surveillance because particularly tertiary health facilities, they generate high volume of data due to high patient turnout. You cannot compare a primary healthcare facility and a tertiary healthcare facility. Sources of health data on disease managed at secondary and tertiary health facilities are also huge and provide data for detection and confirmation of rare diseases because of the level of care. We have data for rare diseases at that level. So this is just summary of implementing IDSR in secondary and tertiary health facilities, like an SOP that was developed actually with the tertiary representative of people from tertiary health facilities and secondary health facilities when we wanted to start implementation and deployment of SOMAs across secondary and tertiary health facilities. As we can see, one of the challenges which we will see later is inadequate number of focal persons at the tertiary health facility. So this was developed to alleviate that. As we can see, you have health facility surveillance steering committee at the tertiary health facility, which is we have the chairperson, and then the secretary could be also the health facility surveillance focal person that liaises with local government DSNO, who is responsible for collecting data across his local government, both at the primary, secondary, and tertiary health facilities. And then, as we can see, we have members of health facility surveillance steering committees who are from various departments, across the secondary and tertiary health facilities, and who have focal persons in each unit where we can have proper coordination. So this is what, essentially, in summary, that NCDC was able to establish or implement. We have conducted, as you are all aware, as I mentioned earlier, we have developed or reviewed or come up with third edition of IDSR technical guideline, which the country needs to, know, especially health facilities. So we have conducted health facility IDSR training across the country in most of the states. And recently we have conducted in 9 states, and we are going to conduct in Ekiti, Kaduna, and Benue very soon, because we have gotten approval for 3 states right now, and we'll definitely secure funding to cover the gap that exists, for those states that are not trained. Then, issue of SOMA's training and deployment, which the DG has graciously addressed yesterday with the state epidemiologists. The SOMA's training and deployment was conducted to 6 states. I think Taraba, Bayelsa, Ebonyi, Kebbi, Kano, and Edo. They were trained and facilities were provided. And now what we intend to do, which the DG has graciously approved, is deployment of SOMAs and training to the remaining 31 states, into secondary and tertiary health facilities in this case. We're all aware the number of primary health facilities that we have across the country, over 40,000, I believe. So it is also something that we're looking at, but Nigeria, as large as it is, with a lot of, with a population of over 200 million, that's a great investment that we feel with time, including private health facilities also, will cover that. But meanwhile, we are focusing on secondary and tertiary health facilities. So challenges limiting IDSR implementation in secondary and tertiary health facilities: occasional lack of case definition in some secondary and tertiary health facilities. Because, for example, patient recorded according to clinical diagnosis outside the case definition, such as patient with disease affecting multiple organs, or syndromes that you may not have, you may not be able to use case definition. The use of clinical terms such as, for example, enteric fever, when you are referring to typhoid fever, and fever of unknown origin. So these are all things that we need to sit down and work out. If not, we'll miss out some, cases that are based on case definition. Multiple departments with few or one surveillance focal person. The structure that we developed that I demonstrated earlier will be able to resolve some of this. And the tertiary health facility, in most cases, not ready to share report or data with the local government DSNO. I think this was discussed with the representative of tertiary health facilities, particularly, and I was able to or opportuned or privileged to lead a team from NCDC to Federal Ministry of Health for advocacy on implementation of IDSR in tertiary health facilities, and we were graciously received, and we have agreed that this is actually the way to go. Then the weak collaboration with national, state, and local health authorities with tertiary health facilities. So I think there's need for us to actually work together, national, state, and local health authorities, so that we achieve the implementation of IDSR in both secondary and tertiary health facilities. We have inadequate interdepartmental coordination across the tertiary and secondary health facilities. That's inside interdepartmental coordination. So communication between departments within secondary and tertiary health facilities can be limited, affecting information sharing and joint response. Challenges also include human resource challenges, workload and burnout, lack of training, so skill gaps, weak data collection and reporting systems, inadequate funding and resources, lack of monitoring and evaluation system for IDSR in tertiary and secondary. But there's something that we must acknowledge. That's the strength, highly skilled human resource, and tertiary health facilities usually are well equipped. So we have these following recommendations briefly. I know my time is almost up. Capacity building and training on surveillance, infrastructure and technology enhancement, which we are trying to ensure that digitalization of data reporting, SOMAS deployment, that's implementation of electronic data reporting through SOMAS, improvement of data quality and reporting practices through the use of SOMAS, resource allocation and funding to support surveillance activities, conduct regular supportive supervision, monitoring and evaluation, advocate to the heads of the institution, which I told you at least we have started, identification of the focal person at all the data generation points or departments, which we have developed with collaboration of the tertiary health facilities and secondary health facilities focal persons. So strengthening communication and coordination channels, identification of coordination focal points in health facility, provision of all the recording and reporting tools to focal points in all departments, and to conduct an orientation for lecturers responsible for community and public health to emphasize IDSR concept and strategies in their lectures. And at the long run, we also intend to advocate for review of curriculum to include IDSR in the medical training institutions. So I think basically what we should be able to remember here is surveillance is a backbone of disease control. So basic ingredients, we have to have a good network of motivated people. We have to have clear case definition and reporting mechanism, efficient communication, basic but sound epidemiology and laboratory support, and good feedback and response. Thank you very much.
So thank you so much, Dr. Muntari, the head of Surveillance Division. So let's appreciate him one more time. Thank you. So for today's session, we would not be taking some questions and answer. We still have panel discussion. All that will be entertained during the panel discussion. So for this session, we still have about 3 presenters, but I would like to appeal to our presenters. Please, let's stick to the 10 minutes that we've been allotted to, so that we can have time to cover up all that we have listed in our agenda. We can see from our agenda we have a lot of presentation. So without further ado, I would like to invite the second speaker in person of Mr. Taju Arowolo. He is the head Early Warning System Division from NCDC. Please, let's welcome Mr. Taju Arowolo for his presentation. Thank you.
40 minutes. Good morning, everybody. Good morning, everybody. Thank God my predecessor has established a well-lined down protocol. So I'll be relying on the protocol established. Tajudeen Arolo is my name. Please, my slide, please. I will be presenting the advancement event in events and community-based surveillance systems in Nigeria. Next slide. This is my outline presentation, and it starts from introduction and hence with conclusion. The background presentation is that early warning system is a vital part of the country's public health system, and in that it monitors, protects, detects public health threats, assesses their impacts, and coordinates timely responses. Early warning system has two components. The first one is the event-based surveillance, and the second one is the community-based surveillance. The system contributes to the overall health security of Nigeria. Next slide. And going further on the background, the function includes coordinate the implementation of EBS, CBS across all levels. Early warning system maintains both the EBS and CBS infrastructures and activities in the country. It further coordinates the management of both systems, the EBS and CBS, data across all levels. It provides feedback to the subnational level on the EBS, CBS data that are collected in line with the IDSR strategy. It builds capacity of staff at the national and subnational levels and its management. Next slide. EBS approach. I want to take the EBS approach. Please come back. The EBS approach is a critical component of early warning system in public health surveillance. It involves collection of data, analysis of data of unstructured information on health and health-related events. The primary goal of EBS is to identify potential health threats in real time, to enable timely detection, improve response, and reduce outbreaks. At this juncture, we'll be thinking in line with 717 metrics. And as you can see, part of the approach of EBS is to go in line with the 717 metrics of early detection, identification, and improve response to reduce the outbreak. What are the key functions of EBS? Basically, is to detect and verify rumor, to document any events that is captured, and escalate such signals for actions. Next slide. We will, please, one after the other, we will be looking at the inception of EBS in this context. It started in 2016, and in 2016, we at the NCDC level, our unit was established in conjunction with University of Maryland. The support of University of Maryland. What were we doing? As at that time, we were leveraging on the Tatafo. Tatafo is to collect information through the social media. It's a replica to the EIOS of the international community. And the Tatafo is just designed for Nigeria context to collect information through the social media. And moving forward, Connect Center was established so that all the informations collected will be modified and housed at the Connect Center. Next slide. Then in 2017, EBS introduced the NCDC 2017 to 2021 strategy plan. And these were the strategic plan that we were using to strengthen the early warning system in the department that time and subsequently in NCDC. We were able to draft the national guidelines, and the national guidelines that was drafted as at that time and inform the JEE score that we had as at 2017 in the range of 39%. Next slide. Next slide. Okay. So in 2018, the digital surveillance workshop with PHE was established, and we evaluated the EBS structure that time. So as at that time, SIT-Aware was introduced to complement the Tatafo platform that we were using. And as soon as SIT-Aware came, there were improvements in information gathered and information disseminated. Then SOP was developed as at that time in 2018, and the reporting templates were updated. Next slide. So in 2019, the SIT-Aware that was introduced was updated. We updated the SIT-Aware. We trained the EBS staff with the support of the CDC and the EIOS training with WHO support. Then we updated the organogram and the team expansion in 2019. Next slide. So in 2020, especially, we introduced a 24-hour operational service in which our staff observe a 24-hour shift, and we are alternating it, and it became prominent during the COVID-19 era, where even the most senior director in NCDC, Dr. Oladejo, he slept in the office quite a number of times, and we slept along with him, all because of getting adequate and transforming the information gotten on time. So moving forward, in 2021, we completed the operationalization of the short code, the 6232 short code that we are using. Since then till now, it's very effective, and 24/7, when you call anybody in Connect Center, you give information, you get somebody that will receive your information. Such a person will process the information using the system that has already been established, and will escalate the information taking action. So moving forward, next slide, please. In 2022, we conducted EBS needs assessment at the subnational level. Next slide. Then in 2023, there were a lot of activities that we embarked upon as far as EBS is concerned, and ranging from validating the National Community-Based Surveillance Strategy Plan, updated the EBS SOPs that were developed in the past. Then we set up EBS working tools to 27 states. In these states, 12 states were supported by the Global Fund project, while the remaining 25 states were supported by the Ready project. Then we conducted the NTOT of EBS rollout. So, next slide. EBS progress and still continuing. Like I said, we established it in 27 states and equipped all equipments to all the needed equipments were taken to those 27 states. And like I said, GF assisted us in 12 states, while REDC assisted us in the 15 states. Meaning that 10 states, as far as we are talking today, is yet to have the privilege of this EBS equipment in their state. Next slide. So what is the next step for us to take as far as EBS is concerned in Nigeria? The immediate next step is to complete the procurement process of EBS in the remaining 10 states. We had sent request to the DG and he has graciously approved that request. And in the process of implementing, making that request achievable, he has taken our request to the procurement to start the necessary procurement processes so that this equipment can be procured and taken to those 10 states. Then we have conducted EBS training, or we are going to conduct EBS training in all the 36 plus 1 state. Having put in place the needed EBS equipment in the remaining 10 states, it will be assumed that all the 36 plus 1 states have been equipped with EBS equipment. Then if you equip the states and there is no training on the usage of those equipment, it doesn't make adequate implementation of the project. So in order to make effective and adequate implementation of the project, there's going to be training in all the 36 plus 1 states so that we will know that we have established fully EBS activity in all the 36 plus 1 states. Next slide. So we'll be talking of the community-based surveillance approach. And community surveillance, as it is one of the essential parts of strengthening surveillance systems in Nigeria today. It entails collection of data, analysis of the data, reporting the health data by community members. This time around, we will be taking this system to the community, to the grassroots. We want to involve the community members to actually own up to their health systems. And in doing that, we'll use community-based surveillance to achieve that. We'll be leaving our respective places, be it the national, the states, and go directly to the community. When the system starts, there are parameters by which we are going to consider to make the system functional in the making use of the community members themselves. So these people will be collecting the data, and the data collected will be used to inform response to disease outbreaks in an effective manner. The key element is involving the community in data collection, analysis, reporting, and linkages with whatever information that is collected within the community. The nearest health facilities of that community, such data will be linked to that health facilities. And subsequently, such data will be moving using the Summers method that my Dr. Mutara has just presented to us. Then the benefit is to include early detection. The moment anything happens in the community member will pick it. Not necessarily sending such information across before it now gets to us in Abuja. No, they will pick it immediately. And as soon as it is picked, the benefit will make such information to improve access to healthcare system. And the community, it will empower the community the more, and our quality data, there will be quality of the data that will be generated because the information is actually picked at the right source. Overall, CBS is a gateway to strengthen public health surveillance and achieving universal health coverage. What we have done is that we have finalized and validated the National Community-Based Surveillance Strategic Plan, the 2023 to 2027 strategic plan. We are waiting to cascade to the subnational levels. In turn, they too will cascade downward. So for now, we have 3 states that we are going to pilot, Oyo and Enugu. We have planned to use the Harvard MD tool as the electronic report. We are going to identify the states on the usage of the Harvard tool to those 6 states. The 3 states that we are going to pilot initially is sponsored by Global Fund, while this 6 states yet is going to be sponsored by WHO. Next slide. So, for us to further strengthen CBS in Nigeria, we will implement CBS in the 3 pilots, further in the 6 states. We will continue to source for funds so